here. Okay. My name is Stephanie Haynes. Welcome everyone. I am the Executive Director of Philadelphia Family Pride. We are the group in Philadelphia for LGBTQ parents, prospective parents, and our kids of all ages. We have social events, we do educational workshops like this one, and when there are in-person prides, we have pride booths at Pride and that kind of thing. We also have a conference in the fall, which it is going to be in October, and we're probably going to have it something like this. So we'll keep folks posted on that. And so I kind of try to think of these as if we were in a room, we would have a sign-up sheet. And so since we don't have a sign-up sheet, we would love to get everyone's information. We have your name and email address from when you signed in, but we would also love to have your mailing address if you have one. We occasionally will send little postcards about events that are coming up. So Taylor, can raise your hand there. Taylor is our awesome intern, and she's going to be collecting information from folks. So if you could sign in by sending Taylor your mailing address, if you're okay with that, that would be great, so that we can keep in touch with you that way as well. We definitely don't send a lot of mail, just so you know, but maybe once or twice a year. As I just mentioned, we're recording this first part, and then we will, we're not going to publicize anybody's personal questions or anything like that, but we at least wanted to capture the presentation part at the beginning, and so we can have that for folks who weren't able to make it tonight. And the last thing I just want to say is that we really normally try to strive for having a diverse representation in our panelists. And unfortunately, we were not able to get any of our Black parents who use donor sperm to create their families to be a part of our parent panel tonight. And actually, we weren't able to get any. There was a couple of trans folks I wanted to get too who were not able to come. And I think what I realized when the other parent and I were talking is that Sandra and I have older kids, and all the people I asked have younger kids. And if you have kids, you know that 6 o'clock is not a good time to try to do something without your kids, because that's the crazy time of day with dinner and bath time and bedtime and all that stuff. But we do have several parents in PFP who would be interested in chatting with folks individually if there's someone whose experience you're not seeing reflected in the panel. We have every kind of family you could think of in our group. There's folks who've co-parented, folks who've used all kinds of arrangements to form their families. So if you don't see that reflected or talked about, please let us know and we'll connect you to someone who can talk to you about that. All right. And Taylor, do you want to talk about what the next event is? This is just one other announcement.
Yeah, I will. So our next event is going to be next Thursday, July 2nd, the exact same time, 6 p.m. And this is going to be about legal implications for building your family. So I'm going to put that link in the chat, and I'll do it again towards the end in case the chat kind of gets filled up with things. But yeah, so hopefully we can see some of you guys there as well.
Yeah, so this session tonight is the first in the series. So we'll have a series of information about, so we have tonight's topic, building your family with donor sperm, and then we'll have other topics about adoption options, becoming a foster parent, a session on prenatal care and birth, etc. So we'll make sure people have all that information. Okay, so now I am going to introduce our folks for tonight. Dr. Gutmann is a reproductive endocrinologist from RMA of Philadelphia, Reproductive Medical Associates. Medicine, sorry.
Okay.
And she's, I think, going to go first, and then Michelle Ottey, we also have, who works for Fairfax Cryobank, and I'm totally blanking on your job title, but you'll tell people when it's your turn. Okay, cool. So I'm going to turn off my audio and my video and let Jackie take it away. And for folks who have questions, you can hold on to them if you want, or you can write them in the chat, and Taylor will run the Q&A in a bit. So I'll see you guys in a little while.
Okay, so hi everybody, Jackie Gutmann. Great picture. I am going to share my screen. And I'm going to share, hang on for 1 sec. I'm going to make that go away. And then we're going to share the screen. We're going to share that screen. We're going to make this big. And then we're going to not go there. Bear with me for 1 sec. And away we go. Display settings, swap. So you now should be seeing a big slide that says building your family with donor sperm. Does that sound right? Good. Nobody, if you're muted, you can't tell me I'm wrong, but whatever.
You're good, Jackie.
Thank you. So what I'm going to do is spend the next 15 or 20 minutes, and I apologize if I go long, talking about building your family with donor sperm. Typically, we've done this in a small group setting. We are here for you, and I think I'm speaking for Michelle as well as myself. We are here for you, and so please liberally use the chat function because we want to make sure that we're able to touch on and address your questions, your concerns. So again, chat liberally. So bottom line is, again, we're talking about building families, and when we build anything, obviously one needs blocks, building blocks to be able to do so. I have used a slide like this for years, and the reason I wind up using this slide is essentially because at least in 2020, we still need sperm to be able to make a baby, we still need an egg to be able to make a baby, we still need a uterus, and oftentimes fallopian tubes are helpful as well. In this case, we're talking about using donor sperm, so we're making an assumption, at least for the purposes of this conversation, that the egg and the uterus are essentially taken care of, spoken for, however you want to look at it. And what we're going to do is spend the next 45 minutes or so talking about donor sperm. Many of you have heard of Corey Silverberg and or read their books, and he writes about building families, making families. Who helped bring together the sperm and the egg that made you? And so in this case, it may be somebody like me and somebody like Michelle that played a role, or not necessarily so. And we will touch on, I think, a number of the different options in terms of using donor sperm for family building. So when we think about sperm, we have to pick a donor. So that's going to be one of the first things. And there are going to be initially 2 choices. One is going to be an anonymous donor or a directed donor. And there are different terms that are used, but essentially a directed or known donor could be a friend, could be a family member, could be somebody that you met somewhere, but it is someone that is somehow known to you. Or you can go to a commercial sperm bank, and Michelle will definitely tell us much more about that. And when you're going to the sperm bank, there are a number of different things that you need to think about in terms of selecting sperm. And again, she'll go through some of those things with you, as will I in a little bit. And you know what? You probably can see that, so I'm going to move that. And so you can see the whole slide. Cost of sperm, I'm going to let Michelle talk about that a little bit. The only thing that I would comment on is that directed donor sperm, so you know somebody, one can make an argument that the cost is zero, is free. I would actually tell you that there is probably nothing in life that really is free, and so that there are costs involved with respect to that as well. In terms of the insemination itself, that will vary depending on what part of the country you live in. Most of you, I'm going to presume, are local. It may vary based on what practice you're in, but it's likely to be somewhere between $300 and $600. And depending on your insurance coverage, may well be covered by insurance. There are different ways that we can time the insemination. One, as we'll hear about, is with blood work and ultrasound. And again, that may well be covered by insurance as well. And if not, the price is going to range probably somewhere between about $800 and $2,000 per cycle. So when we think about third-party reproduction, we're essentially thinking about involving a third or more person, or people, I guess would be the plural, persons, in this process. And one would like to think that it is a private matter, but unfortunately, it is, as again, we'll hear a little bit more from Michelle, it is not a private matter. The government actually plays a role in what we do. And so the Food and Drug Administration, the FDA, actually largely plays a role in how we screen sperm for communicable diseases. And in fact, if you're using somebody that you know, a known or designated or directed donor, they too, if you're coming to a fertility practice, need to be screened. The FDA tells us that this is what we do and this is how we need to do it. The little cartoon, if you can't read it, some guy standing at a lectern who said, we heard that laughter is the best medicine, so beginning Monday, we'll be regulating it. Bottom line is they absolutely have a hand in what we do. You'll hear from Michelle about that. Each practice may have their own policy with respect to whether the sperm needs to be quarantined or frozen for a period of time before it's used with rescreening. And we typically, again, will adhere to guidelines established by our society, which is the American Society for Reproductive Medicine. So that these are not whimsical decisions that are being made. Before we get started, we often want to do an insemination. So we're starting with the presumption that there's an egg or multiple eggs, there's a uterus, typically not multiple uteri, at least in one person, and then we need the sperm. And so we start with, on some level, a basic presumption of fertility. And so what we do to evaluate this is obviously we talk to somebody. So is there any history that might suggest a problem with the uterus? Is there any history that might suggest a problem with fallopian tubes? Certainly, if there is, we want to evaluate it. But in all honesty, even if there's not, I engage in a conversation with my patients about, should we be testing your uterus? Should we be testing your fallopian tubes? And the reason for that is sperm is not inexpensive. And so the question becomes, do you want to double check? Do you want to be sure before spending that money? And so one of the ways to do that is with something called a hysterosalpingogram, where we take a catheter, we put the catheter into the uterus, we squirt contrast material in, it flows into the uterus and gives us an impression of the contour of the uterus. It then goes out into the fallopian tubes and ultimately, hopefully, spills out of the tubes. And so this would be a normal study. And you can see that this is also white, but this is like a big, round, white thing. And so this is an individual who has blocked fallopian tubes. So again, this would be normal, not so normal. There are other ways that we can do it as well. We can do it with saline and using ultrasound. The image is perhaps a little less precise, but also gives us information. This is not something that we mandate that people do before they get started, but certainly as part of the counseling, we discuss what the test itself is and what the value of the test is, and in all honesty, what the potential risks are. And those risks would be infection, which is very unlikely, or reaction to the contrast material, which is even less likely. They both are crampy studies, so we certainly have people take whatever their non-steroidal drug of choice may be. Other things when we think about getting pregnant, so we talked about the uterus, we talked about the tubes, we need to talk about the eggs. And so there are different ways for us to be able to assess the eggs. We are born with all of the eggs we will ever have. As we get older, we use them up. And unfortunately, we use our best eggs first. And so women are more fertile in their 20s than they might be in their 40s. So if somebody has eggs are more likely to achieve a pregnancy in their 20s than in their 40s, and it declines over time. And the best way to assess this is with something called an AMH, or anti-Müllerian hormone. It's a hormone that correlates with the number of eggs that somebody has. And the older they get, the lower the value is. Somebody with a lower value will have fewer eggs. You can also check FSH, it's a blood test. That actually goes up as the number of eggs decline. As a cis female ages, she will have less eggs, and as a result, her FSH level typically will increase. And we can do ultrasound and we can look at the ovary. So this is an ovary here. These are follicles in the ovary. Follicles hold the eggs. Now, there are follicles all through this area here, this whiter grayer area, but they've not reached a stage of development where we can see them. Once they have fluid, we can see them, And the more of these black circles that are present, the greater the number of eggs. Again, this is not all of the eggs, but representative of a small sample. So we use that information together to calculate somebody's or determine somebody's egg reserve, which plays a role in their ability to get pregnant. Other things that we do that are not directly related to achieving a pregnancy, but I would actually call, quote unquote, housekeeping, for lack of a better way, is to do genetic testing. And so we're all made up of genes. Our genes carry a bunch of information on them, and sometimes things can go wrong and you can have a mutation. Most disorders that exist are what we call autosomal recessive disorders, which means that you need to have 2 abnormal genes to be able to have the disease. And so in this case, this happens to be a kidney disease, but the abnormal gene is colored purple. The normal gene is colored green. So each of these individuals is half purple and half green. As they make children, they can get a purple and a purple, and so they'd have a purple child in this case. And so this child is affected with the disease. The child can get a green and be totally free of disease, or can have 1 purple, 1 green and be free of clinical disease but carry the mutation. And so what we offer individuals as they're trying to achieve a pregnancy is what we call expanded carrier screening, which screens for approximately 283 different disorders, so that information is available to them if they are interested in having that information. And the value, again, is to try and avoid the potential of having a serious disease. As I'm sure you'll hear, this testing is similarly offered to sperm donors. Or let me rephrase that. This testing is automatically done on new sperm donors, and so that information would be available to you to compare with what you have. The other thing that we do screen for is cytomegalovirus, or CMV, which is a virus that is easily transmitted. About 40% of us have been exposed to it. Not a big deal, runny nose. You know, in this day and age, I guess it could be confused with coronavirus, but it's not at all. But, you know, runny nose, just an upper respiratory infection. But if you get it when you're pregnant, the baby could unfortunately be affected, have calcifications in the brain, and so it's a pretty crummy thing. The donors are screened for CMV. They're screened for having had disease in the past, as well as the potential for active disease. If it is believed that they have active disease, they are not included in the donor pool. Thus far, there really is no data that suggests that CMV can be transmitted through sperm, but the donors, as I said, are screened, and we do screen our patients and typically recommend that if a patient is CMV negative, that they pick a CMV negative donor, but they don't have to. But it, again, is something to think about in selecting donor sperm. So how do you time insemination? So now we have the sperm, we've looked at the uterus, we've thought about the tubes, we may have checked the tubes. How do you time the insemination? So you want to put the sperm where it needs to go when the egg is there, when ovulation occurs. Some people will use temperature charts. Temperature charts will only show you that you have ovulated. The temperature goes up after ovulation. It can't be used to predict ovulation. Some people will use cervical mucus, but cervical mucus is pretty crude, and you can have great cervical mucus not exactly at the time of ovulation, and you can have not so great cervical mucus at the time of ovulation. There are a gazillion apps that are out there that will help you predict your fertile window. You can use an ovulation predictor kit, little smiley face that says peak fertility, and you're typically going to be ovulating the next day. We can use blood work and ultrasound. So this is an ultrasound that shows a mature follicle, so it's a big black circle. And you see this very pretty uterine lining, and you take my word for it, it really is very pretty. Should we use medication when we're thinking about doing insemination? And so the medications that we can use would be Clonid or something called letrozole or Femara. But there was actually a very, very nice study that was looking at same-sex cis female couples who were using donor sperm, and essentially found that the likelihood of having a baby was not different, ongoing pregnancy, live birth rate, whether they used medication or natural cycles. And so in all honesty, if somebody has regular cycles, at least initially, I don't recommend using medication. It's certainly something that we talk about, but I typically don't recommend it. And the one thing you'll see here is that the likelihood of having a multiple pregnancy, not using medication in this case, was 0 out of 43, but 6 out of 51. And there's always a risk with a multiple pregnancy of premature labor, premature delivery, and the complications that can result. How do we do insemination? So you can do insemination at home. Typically, one does not use a turkey baster. Turkey baster is quite large and ejaculate volume is quite small. But you can use a syringe at home with a needle attached, collect the sample, draw it up, obviously take the needle off, and then put it in the vagina and do a vaginal insemination. This is an intrauterine insemination, speculum in the vagina, catheter slides in to deposit the sample. There are devices that are sold for home insemination. I would argue that the syringe works just as well and is probably about $81 less expensive. I think this sells for about $83. This little area over here looks at the likelihood of getting pregnant with vaginal insemination versus intrauterine insemination. And ultimately, the likelihood of getting pregnant if you are using frozen sperm, which is what you're going to get from a commercial sperm bank, is going to be greater. Or anytime that you come to a doctor's office, reproductive endocrinologist's office, is going to be greater if you do intrauterine insemination as opposed to vaginal insemination. So that if you are treated in a reproductive endocrinology office, we do recommend IUI, intrauterine insemination. Likelihood of getting pregnant with IUI is going to be greater if somebody is younger, and so the cumulative pregnancy rate in somebody who is 20 to 29 years of age is going to be, after 12 cycles, about 75% or so. I'm sorry, I take that back, about 80% or so, 85%, which is what you would expect in somebody who's been trying to get pregnant for a year. The older somebody is, the less likely they are to get pregnant in any single cycle of insemination. What happens if somebody doesn't get pregnant initially? They've done a number of inseminations, they've not achieved success, we've moved on to use medication, they've not achieved success. Ultimately, one of the next steps is going to be IVF, or in vitro fertilization, where we take the eggs out of the ovary, put them in a dish with sperm, and eventually put them back into the uterus. We use a bunch of different medications to be able to do IVF, and we have a stimulation protocol. It's on average about 10 to 12 days of these medications before we go ahead and do egg retrieval. In order to titrate the dose of medication, we monitor with blood work and ultrasound. So if you think back to that other picture with that single black circle, that's what we normally have, is one egg that matures. Here we can see a whole bunch of little black circles, or bigger black circles, and these are ovaries that have been stimulated. So when we monitor, we collect this information as well as blood work. The egg retrieval is typically done in a surgery center. IV sedation typically takes about 10 or 15 minutes. Usually hang out with us for less than an hour to make sure you can eat and drink, and then we send you home and tell you to rest. This really is one of our nurses. I keep this picture, it's about 25 years old, but she likes looking at it. The risks with the procedure are bleeding, infection. The likelihood of having any problem is going to be very, very small. So essentially what happens is we use ultrasound, guide the needle into the follicle. So this is a big black circle. We suck this out, the black circle disappears, we move into the next black circle, the next black circle, and so on. And so graphically, it would look like this. We then take the fluid that comes out of the follicle, we pass it off to the embryologist. They look through a microscope into a little dish, and ultimately they will see eggs. And then what we want to do is we want to put eggs and sperm together. And this is what it would look like if we just took an egg and surrounded it with sperm. And ideally, this is what happens the next day. We can see fertilization, and these are the pronuclei. So this is the genetic material from the sperm, genetic material from the egg. Sometimes that doesn't work well on its own, and typically frozen sperm has a little bit of a lower fertilization rate. So we typically recommend doing what we call ICSI, or intracytoplasmic sperm injection, where we pick up a single sperm and inject it into the egg. And this is one of our embryologists sitting at the microscope. She controls everything with these joysticks here, and that's what she is actually working with. What she's seeing under the microscope is one pipette holding the egg. This is the shell of the egg. We need to get through the shell of the egg, and this little dot right here is the sperm. Pokes through, deposits the sperm, pulls the pipette back out, and then again, we hope fertilization will occur. And so this would be a fertilized egg. This is what the embryo would look like about 3 days later, and this is what an embryo looks like about 5 or 6 days later. This is a blastocyst, and this is a very beautiful blastocyst. Ultimately, what we typically do is actually freeze the embryos. We allow the individual to shed their uterine lining. That allows us in the subsequent cycle to build a uterine lining that's actually more receptive for the embryo transfer. For the embryo transfer, we use abdominal ultrasound to watch our catheter go into the uterus so that we can deposit the sample. And this is what it would look like on ultrasound. And this is a little cartoon version where they draw up, in this case, 2 embryos, but we typically will only transfer 1 embryo and then slide it into the uterus. We do, as we talked about previously, freeze embryos, both to allow us to synchronize the uterine lining with the embryo, and also hopefully if an individual or a couple has additional embryos that they can remain for further use. The likelihood of success is going to be dependent again upon the age of the egg. This is data from 2016 and illustrates that as the egg gets older, the likelihood of going home with a baby does drop down. These are national numbers, about 48% under 35, 35%, 35 to 37, 22%, 11%, and so on. In terms of cost, the medication costs depend on how much medication an individual needs, but typically will vary between about $4,000 to $7,000. The medical costs will also vary between 8 and 16, depending on where you go. This typically will include the monitoring, the egg retrieval, the embryo transfer, the culture, freezing, and I included a cost for co-IVF, where a same-sex cis female couple may elect to have one partner provide the eggs and the other partner provide the uterus. And ultimately, we go through all of this to be able to obviously achieve a successful pregnancy. I'm going to actually stop now. I can touch on COVID, but I think before doing that, maybe turn it over to Michelle, because I'm sure I've exceeded my time, but certainly will be available to answer any questions about COVID if you have any. Thank you. All right. Stop share.
Okay, thank you, Jackie. You touched on a lot of stuff that I am also going to talk about. So let's pull my screen up. Okay, so hopefully you guys can all see my screen. I just have a couple of slides that I hope will be beneficial. I am Michelle Ottey. I'm the lab director at Fairfax Cryobank, and I am happy to be here tonight with all of you. Jackie and I have done this a couple of times together. So our talks really do pivot off one another. So obviously we have the same goals. You need an egg, a sperm, and a uterus. And I am going to talk to you about sperm. Not knowing exactly who's in the group tonight, I'm going to focus on the donor sperm aspect, and then if there are specific questions about directed or known donors, I can answer those questions as well. You do have 2 options when you're talking about using donor sperm. You can use a directed or known sperm donor. This is someone that you know but with whom you're not sexually intimate. And if you're going to work with the cryobank and the physician's office, this process is going to be regulated by the FDA, which Jackie mentioned. So that what that means is that your directed donor will have to have a physical exam, will have to have all of the infectious disease screening, and depending on the state in which you're using the sperm, there may be some additional genetic testing that's required. And one thing to consider is that if samples are produced beyond 1 week of when all of that testing occurs, they have to be held in quarantine for a minimum of 6 months. And so you really want to consider that when you're thinking about your timing. That's an FDA regulation. So, you know, if some physicians will waive quarantine, but again, they can only choose that if the samples are produced by your known donor within a week of the physical and the infectious disease testing. The other option is the donor sperm option, and that can be a little bit easier to navigate in some instances, because when men are signing the agreements with the sperm bank to be a sperm donor and participate in the program, they are relinquishing all parental rights. So one of the things I will mention just briefly about directed donation is, though we don't require it, we highly recommend that the directed donor and the recipients work with legal representation and possibly also mental health professionals to really explore the expectations of the relationships and the legal responsibilities of the parties involved. You don't have to worry about that with the donor sperm from the bank, because we take care of that part for you. It is really important to remember that not all sperm banks are alike. There are some big differences and some subtle differences in the programs, and I'll go through some of that, and I'll be happy to answer any specific questions that you have. Our sperm bank donors, you know, we're always working to diversify and improve and increase our donor catalog. We want to have enough diversity in the donor pool to meet the needs of you all, the recipients. It is not easy to be a sperm donor. A lot of people think that, you know, you can just sort of walk in off the street, get $50 and produce a sperm sample, and that's so not the case. Only about 1 in 200 of the initial applicants actually make it through the screening process into the donor program. They have to provide 3 to 4 generations of medical history. I say 4 because if they have their own children, they provide us with that medical history as well. We do 3 or 4 screening samples of their semen to ensure that the specimen quality is good. They actually have to be above average for what the World Health Organization will indicate as the parameters for a healthy sperm sample, because they have to survive that freeze thaw process in the liquid nitrogen. So we do that. They have physical exams, infectious disease testing, which I'll get to and tell you a little bit more about, genetic disease screening. We do eligibility questionnaires at every visit. We do background checks. They complete a psychological screening called the Personality Assessment Inventory, which is a psych screen that is used to rule out anyone with a psychopathology. We do double verifications of their ID with biometric thumbprint verification and a physical ID. We verify their transcripts or their diplomas, and they have multiple meetings and interviews with our staff. So it's a really rigorous screening process. It takes 6 weeks-ish to get through, and then we would start doing that infectious disease testing. As we mentioned, this is an FDA-regulated process, and so FDA requires certain tests for infectious disease that all sperm banks will do. We do a couple of extras at our molecular infectious disease testing lab at our parent company of genetics and IVF. We do test for HPV 16 and 18, which are 2 strains of HPV that are causative factors in cervical cancers. We also look for HSV 1 and 2, herpes simplex. And we do, Jackie mentioned the CMV virus. We do some CMV antibody testing, which is required, but we also do CMV NAT or DNA testing of the semen to ensure that there's no shedding virus that would be present in the semen sample. Now, along with all of the infectious disease testing, we also do expanded carrier disease testing on our donors now. Prior to that, we sort of have an array of genetic testing on our donors based on the technology that was available at the time that they donated. starting in January of 2018 and going forward, we started doing the expanded genetic disease testing. And we will do, and some other banks might do, a special testing request. So for example, you know that you're a carrier for disease X, but it's not part of the autosomal recessive expanded carrier panel. You can work with our genetic counselor to have special testing done on the donor that you're interested in to ensure that he's not a carrier. Jackie already talked about the carrier screening and the possibility of the you know, being a carrier, having an affected child or unaffected child. We do sell donors that are known carriers, and in those instances, just as an aside, we're all basically carriers for something. We just don't know it. So these donors are accepted into the program if they're a carrier for an autosomal recessive disorder that doesn't have any symptomology or presentation as a carrier. So if they're a carrier for disease X and you're a carrier for disease Y, you're okay to use that donor. If you're both carriers for disease X, then you wouldn't use that donor because you wouldn't want to have an affected child. Now, whenever I speak to groups like this, one of the things that comes up is, you know, there's so many donors to choose from. How do we do this? Right now in our catalog, we have 470 donors that you can choose from. So the thing that I always recommend is to start by creating a list of characteristics that you value. I will just mention, I did a webinar this past Wednesday about how to choose a donor, and it is available on our website. If you're interested, it's about 30 minutes and then a whole question and answer section about how exactly, you know, you should go about choosing your donor, and our customer service staff, the assistant director was on there as well and answered a lot of questions. So that could be a good resource if you're at the point of looking for a donor. But I said the same thing in that webinar that I'll say here. It's really good to start with that list of characteristics that you value, be it physical features, ethnic background, education, anything that you really value in another person and in yourself. That's a good way to start whittling down that list. And you can go right to the donor search and you start looking. I just wanted to mention we do have an unlimited access package. You can look at this in more detail on the website. You know, I just am trying to present information tonight. It's not a sales pitch. We do have a lot of products that will help you choose your donor. Almost all sperm banks have a plethora of information on the sites that'll help you, whether it be photos or profiles. I do want to mention the summary profile on Fairfax website. We reach out to our donors annually to ask them for updates to their medical history and their family's medical history, because as you can imagine, when they're completing the initial medical application and they're working with us, that's sort of a snapshot in time. We're typically dealing with men. The majority of our donors are aged 21 to 29, about 60% of them. So if you think about being 21 to 29, you know, your parents and grandparents are probably alive and healthy. And so we want to collect information over time so that we have that updated information. And the summary profile, which is free on the website, is where you can see those updates documented. There's a lot of information, photos and audio clips, staff impressions, all of that's available for you. And one thing I'll mention, this also comes up a lot in family building seminars, is, you know, what's the difference between the non-ID and the ID donors? What should I use? And ultimately, it's a very personal choice. You should make the choice that is right for you. A non-ID donor, previously called anonymous donors, these are men who participate as sperm donors, but they have basically asked not to allow to have their identifying information released. ID donors, or some other banks will call them willing to be known donors, or ID release, ID option, something like that. You know, the general idea is that the identifying information will be released to your child when they're 18 or older. Now, there is nuance in the programs. I can tell you the detail of our program, which is that when your child reaches 18, they can contact the cryobank if they want to. It's not required. They can contact the cryobank and ask us for the donor's identifying information. We will at that point, as a courtesy, reach out to the donor, ask him their, you know, his preferred method of contact, and then share all of the contact information, identifying information with your child, and then indicate if he had a preferred method of contact, email, text, whatever. If the donor doesn't get back to us within 5 or 7 business days, we're just going to go ahead and give your child all of the information, and then you can go ahead and they can go ahead and contact them. But we wanted to do the courtesy of letting them know what the best way to contact them would be. Again, this is a really personal choice of what to use. I will tell you that starting this year, we are now only accepting guys into the program that are going to participate as ID donors. And the reason we made that policy change is that this is really the direction of the industry, both internationally and domestically. We're really seeing increased feedback from recipients, from donor-conceived individuals, and from previous donors that indicates that this is really the way forward. We are also taking into consideration regulations. A lot of international regions have very specific regulations that require ID release and registries. The state of California actually passed passed legislation in January, or that was effective in January, that requires that non-ID donors be able to request that the sperm bank does in fact release their identifying information. And so we've set up a process by which any of our previously non-ID donors can request that. We're not changing them to an ID donor, but we are indicating that on that summary profile. So that's just a little background on the ID versus non-ID. I mentioned, okay, so it's 65% of men that are actively donating with us are between 20 and 29. About 45% of them say that they know someone that's affected by either social or medical infertility. 40% of them have donated blood, 20% are married and or have kids of their own, and 15% have donated plasma. This is really something that a lot of people are interested in doing because, for the altruism, because they want to be able to help someone else. Once you choose your donor, it's really easy to place your order. You can chat with a client service rep. You can place it straight online. You can call and speak with a client service rep. You'll complete an easy online terms of use. You'll place your order. There's a couple of bits of information that you're going to need when you're ready to order your sperm, which is the clinician's information, the preparation type that you want, which I'll talk about in a minute, and then when you want it to be delivered. Now, Dr. Gutmann went through the difference between the intracervical or ICI and the intrauterine or IUI preps. We actually sell sperm that's already pre-prepped for those things. If you're doing an intracervical insemination, an ICI, you can order an ICI prep. We actually also have a recorded webinar about home inseminations. If you are interested in that, it's available on our website. And if you indicate to our client service rep that you're ordering sperm for a home insemination, we'll actually send you instructions and a syringe, a needleless syringe. I think we actually send 2 syringes with each order. So you can, for a home insem, you can actually use any of the prep types, but ICI is all you really need. It's a lower cost option because there's less manipulation of the sample. The IUI is pre-washed. That means that the seminal fluid is removed from the sample and then resuspended in a freeze media, and that would be ready to go for an IUI with the doctor. And then we have ART, or assisted reproductive, technology vials that have fewer cells. Dr. Gutmann went through the IVF slides, and as you can imagine, you need far fewer sperm to fertilize an egg in a dish than you need when you're placing it onto the cervix or into the uterus when it still has to make its journey up to the egg. So if you wanted to purchase a specific donor, and let's say the donor only had ART vials left, but you were doing a home insem or an IUI, you can always purchase 2 of those. Again, they're lower cost, and combine them for one insemination. Your physician or your medical health provider is going to advise you on the quantity and the prep type that is best for you. And the question of cost is really important because this is not an inexpensive process. Vial prices are going to range anywhere from $615 to $1,100 depending on the prep type and the donor category you select. So ID donors are a bit more expensive, and the IUI vials are more expensive because there's more work that goes into preparing them. And then you choose either to store the samples, and you can store with us, or you can ship right away. And we do have 3 different shipping options, and the costs are here on the slide. And that was what I wanted to share with you guys. I'm happy to answer any questions.
All right, thank you guys so much for your time. So there were a couple questions written as you went along that I can read off, and then if anybody has more questions, feel free to put them in the chat. So the first question, this was directed towards Dr. Gutmann, was, do you take clients from Delaware?
Sure, absolutely.
Okay, that was quick and easy. If you are older but froze your eggs, are your chances similar to someone who is 25 to 29 years old?
So your likelihood of getting pregnant is going to be based on the age of the egg when it was frozen. And so if you froze it at 25 to 29, the answer is pretty much yes.
Okay. And would you recommend trying a cycle of home insemination for a healthy 32-year-old or go straight to IUI?
So I honestly think it's a matter of preference. And so there are definitely people who prefer to do home insemination to try and avoid medicalizing, what's a very private experience. The pregnancy rate will, if you're using commercial sperm, be a little bit lower by doing a home insemination than by doing an intrauterine insemination, which typically, not always, but typically does require a doctor's office. And so then it just becomes a matter of, gee, do you want the extra few percent by going to the doctor's office, or would you prefer, because you may well get pregnant quite quickly at home, would you prefer doing it at home, again, with a slightly lower likelihood of success? The other thing that I'd like to throw in now is we can use, if you're doing an insemination in a doctor's office, I think any reproductive endocrinology office can prepare sperm so that if you were to buy ICI vials, we can then use them and turn them into IUI vials. So the work that, for example, Fairfax or any other bank does before the freeze to make them IUI, we can do once we thaw them. And so that depends on A, what's available, and B, honestly, what your insurance covers. So we do charge for preparing the sperm, but if your insurance actually covers insemination, we bill it to your insemination. So you may save a little bit of money because that work, which is done by us in this case rather than them, is paid for by the insurance company. But again, I would go along with exactly what Michelle said, which is, you have to see what's available, but we can work with either IUI or ICI. If you're doing insemination at home and just putting it in the vagina, you would typically recommend doing the ICI. It's less expensive. I mean, it's just, right. There's no reason to go the other way. We can also store sperm so that if, and I didn't touch upon this, but the likelihood of getting pregnant in any single cycle of insemination is reasonably low. We anticipated, again, it depends on the age of the egg, but we anticipated being somewhere around 12 to 15%. So oftentimes people will need more than a single vial, and shipping is not inexpensive. I think that if you live in the Philadelphia area and you're going to pick up sperm from the Fairfax office here, because there is an office here, there is a discounted charge. You don't have to pay FedEx, but there is some charge. Is that right?
Yeah, so you would pay to ship all of your vials once to store with us here in Philly, and then there's just like a processing paperwork handling fee of $45 each time you pick up, instead of paying the $200+ for the shipping.
Right. So we can store sperm as well. We do charge as well for sperm storage. The other thing that I think you did not mention is that if somebody purchases sperm and they've built their family more quickly than they had anticipated, and the sperm does not leave the bank, you will buy it back perhaps Correct. At 50%.
Yes, so that's only if it's been stored with us at one of our locations. Once the sperm leaves our facility then we can't do a buyback because obviously quality control. But if it's stored with us at any of our locations, we do a 50% buyback.
So sometimes for practical purposes, people are thinking about perhaps having 2 children. It's important for them to use the same donor. They buy 12 vials of sperm. They ship the first 3. They get incredibly lucky. They get pregnant the first time with the first vial, and the second time with the third vial, they didn't get pregnant once. They've now used up their 3 vials with us, but have 9 vials left with Fairfax. So, you know, there's no right answer to how many to purchase at once. There's no right answer to evaluate how many to ship at once, but those are the things to be taken into consideration when you're planning.
Okay, great, thanks. And then, do you ever transfer 2 embryos if someone wants twins?
So we don't aim for twins just because of the greater risk, but we will not refuse somebody what we call a double embryo transfer. We certainly will counsel them regarding the risks associated with a multiple pregnancy, but we do not refuse anybody.
I think you might have touched on this in the last answer, but I'll just read off. How many vials do you suggest buying at one time for IUI?
So there's no right answer to the question. Part of it has to do with, honestly, as well, what your resources are, how many children you think you want to have, and how committed you are to using the same donor. And so, again, the likelihood of getting pregnant with just 1 cycle is going to be very small. And so typically, you know, I sort of suggest 3 vials, but honestly, that may not be enough. And that may be too much, but it to me seems like a little bit of a compromise just based on the likelihood of success.
Okay. How many IUI cycles should you try before moving on to IVF?
So again, no absolute right answer. Part of it depends on how much sperm you have available, how old you are, what your testing looks like. But typically we recommend somewhere between 3 and 6 cycles before moving on. But again, there are going to be variables, both medical and otherwise, that would influence that recommendation.
Okay. Can you explain the CMV status in further detail?
So not my favorite. So CMV is really extraordinarily common. And so again, about 40% of us have been, if not more, have been exposed. And so if we have been exposed, the likelihood of contracting a severe CMV infection that could be transmitted to a fetus is going to be remote. The most likely place, honestly, for us to get CMV might be in a supermarket. It's community-based primarily, but it can be sexually transmitted. There really, my understanding is, has not been a documented case, and please correct me if I'm wrong, of CMV transmission from sperm. The sperm banks do screen, and I'm going to let you go into that again, but we do provide CMV status to our patients. Out of the utmost caution and without absolute medical evidence, we suggest that if they are CMV negative, to go CMV negative, though we don't require them to do so, because again, the risk is, one can never say 0, I guess, but it's pretty darn close to 0. If somebody is CMV positive, their risk of getting a severe infection from anywhere, forget about the sperm, from anywhere, is so small that it really doesn't matter. And I'll let you go into the testing a little bit more and why the sperm is as safe as it is.
Sure. So all of the donors are getting tested for a test that's called CMV total antibody. And what that's telling us is if the donor has had a previous exposure to CMV. So if you see on our website or on any of the websites that a donor is listed as CMV positive, that only means that he's had at some point a previous exposure to CMV. What we do then is we do additional testing. We actually, on all of the donors, we submit a small portion of the semen sample for testing by, it's called nucleic acid testing, or PCR, polymerase chain reaction. And it's a really sensitive DNA test that is looking specifically for the virus in the semen. If we find virus in the semen, that sample is thrown away. Samples are back tested. Anything that's positive is thrown away until we get 2 consecutive negatives, and then those samples are kept. So basically, the samples that you're getting from either a CMV negative or a CMV positive donor have all been tested and are assuredly, again, you can never say 0% chance, but they are assuredly going to be safe because there is no detectable CMV virus shedding in the semen.
And you said you test all of the guys.
We test all of our donors. So if they're CMV positive or negative, we do the NAT testing, and we actually just changed our protocols to start reflexing to the IgG and IgM. So what that means for everybody is basically if you are IgG positive, that's a previous exposure. If you're IgM positive, that's an active infection. So we're doing a third type of testing on top of it. It's a regulatory thing.
Thank you. If there are no more vials from a particular donor available, does Fairfax contact the donor to find out if they're willing to donate more?
Okay, so it depends on a couple things. One, if the donor has met his family limit and he's sibling only, we would only ask for a donor reactivation, which is a separate process on, that you would work with us through, if you have already reported a birth from the donor. If it's just the donor ran out of inventory, never met his family limit, we can ask them. It is a reactivation is what we call it. So basically we would only reactivate them for someone who was going to purchase them. We don't just do it randomly. We try to monitor the amount of sperm that we get from each of the donors so that we don't exceed our family limits, which is in the United States, we work to limit to 25 families. I do really want to point out that if you do use donor sperm, it is critically important for you to report your pregnancy and birth back to the sperm bank so that we can track the number of families and keep it to a reasonable number. We've decided to go with 25 in the US. We have other donors who are international, and we adhere to all of the international limits as well. So the sort of short answer is we can do a reactivation if you have a reported birth from a donor.
Do you know what insurance will cover the inseminations?
So a number of them do. It depends obviously on the specific plan that you have, but most Keystone HMO will cover it. Many personal choice plans will cover it. Aetna plans are a little bit more complicated because they often don't cover social infertility if it is managed by Aetna, but would cover it if it's perhaps managed by the employer. That's not a great answer, but that actually is the answer. And then there's some of the smaller insurances like Cigna. Again, some of the plans do, some don't. United, some of the plans do, some don't. But Keystone HMO does always, actually.
Okay. Does gonadotropin therapy increase the number of eggs released versus Clonid?
Yes. So the risk with Clonid is a multiple pregnancy, so the likelihood of having twins with Clonid is about 5 to 8%. Same really is largely true with letrozole, maybe a little bit less. Likelihood of more than twins with either of the oral medications, Clonid or letrozole, is going to be very, very small. I mean, it's less than 1%. The likelihood of twins with gonadotropin therapy is about 15 to 20%. The likelihood of more than twins is about 2 to 3%. And other than Octomom, which many of us have probably seen on the cover of People magazine, most of the high order multiples where you see, again, also on the cover of People magazine, those are typically a product of gonadotropin therapy.